Hello, I'm Dr. Jacob Bornstein. Nice to see you all. I will be moderating today's session. I'd like to start with first thanking you all for joining us today for our virtual Coffee with the Experts. Today, we will discuss for 1 hour the many challenges and issues that we face when deciding how to put together and submit data for publication, and a few tips to increase the acceptance chances. During the hour, you will be able to present questions of your own in the Q&A box below. In the next few moments, I will introduce the speakers, myself, and the ISSVD, which is the international society that organized this seminar. So you have a few minutes now to bring your coffee and join the session. I will first introduce myself. I'm a professor of obstetrics and gynecology in the Bar Ilan University, Faculty of Medicine in Israel. In previous years, I served as chairman of obstetrics and gynecology for many years and as a president of the International Society for the Study of Vulvovaginal Disease, the ISSVD. Currently, I am the editor-in-chief of the Journal of Lower Genital Tract Disease, the JLGTD, which is the journal of the ISSVD, the ASCCP, American Society of Colposcopy, the Australian, Canadian, the Israeli Colposcopy Societies. I publish studies on both clinical and translational science. Most probably, you came across my name as the author of the ISSVD and IFCPC terminologies of the cervix, vagina, vulva, vulvar pain, and vulvar VIN. One more thing before I introduce my colleagues here. At this time, I would like to invite you to join the ISSVD if you are not already a member. You can do this with the QR code, which is behind me. As a member, you will have opportunity to network with us, join the active email listserv, where you can present difficult cases and get immediate answers to your questions from our members. Use a great image archive and a resource library and many live and online events like this one. In addition, we hope that this webinar will assist you to prepare your abstract and ultimately the manuscript for our upcoming World Congress. This live event will be held in Ljubljana, Slovenia, from September 16 to 18, 2024. So you have more than 1 year to prepare. It will be preceded by our International Vulvovaginal Disease Update on September 13-14, 2023. Be sure to visit our website at www.issvd.org to learn more. There will be networking event planned in addition to an amazing scientific program. Without further ado, let me introduce my colleagues. One of them is already here, and I will start with him. Dr. David Foster is here with me. Actually, he is my predecessor in the Journal of Lower Genital Tract Disease, where he served as the editor-in-chief for 5 years. There, he emphasized the development of core outcome sets for our studies. Dr. Foster is professor of obstetrics and gynecology with a particular focus on vulvar pain. He has acted as PI in NIH and other funded large-scale controlled studies, such as a randomized crossover clinical trial studying gabapentin treatment for vulvodynia. He has developed and published a novel pain outcome measure for vulvodynia treatment. A major focus of his professional career has been to discover the etiopathogenesis and treatment of vulvar pain. And he is a role model to me. The other speaker today, I'm not sure that she is here already, but she will join us, is Professor Mara Kirgiou. She is a professor and consultant gynecological oncology surgeon in gynecology at Imperial College London and Imperial College NHS Trust. I am sure that you came across Dr. Kirgiou's name in publication dealing with the effect of conization on future pregnancies. Among many other things, she is the chief investigator of the novel trial assessing the value of HPV vaccination after colonization for CIN. She also studies the use of HPV biomarkers in personalizing the management of women with abnormal finding at screening. She has developed an interest on the role of microbiome and host interactions in gynecological cancer. Professor Kirgiou contributes to the number of national and international committees, such as the ESGO Prevention Committee and chairs and the BSECP Research Committee. So I think we are ready to start with our webinar today. And I would like to start with you, David. There are all kinds of and types of studies, cross-sectional, case control, cohort. My question to you is how to get the most out of your data set. In other words, how to use the data, how to plan the data, and how to come up with a good study, David.
Thank you, Jacob, for the kind introduction. And I'm going to start out with several comments before reviewing some things. First of all, basic research, biomedical research can be divided into either experimental or observational research. And
David, just one word to Mara. She just joined us.
Hi, Mara.
Mara, I have already introduced you and presented you, so now you have to live up to the expectations.
Oh, what did you say? Good things, I hope.
Of course. David, go on. I started with David since he was here.
All right. We're going to focus mostly today on observational research, mainly because experimental research requires quite a bit of planning ahead of time. And I think most of our people that are on this teleconference probably have data sets that are already present. And therefore, we're really kind of running that more toward an observational type of design. There are important comments, though, also before we start. It's important to assume that everyone has IRB approval of their work. Almost any journal that you're going to be publishing in these days is going to require you to cite your IRB approval. And it is also important to make sure that you maintain confidentiality of your subjects. And this should be really part of your design.
Now, David, with observational studies, do journals require sometimes a clinicaltrial.gov registration?
Generally not. You can usually do a case control study without clinicaltrials.gov. The thing about clinicaltrials.gov is they're trying to lock you into a defined outcome, primary outcome measure, which is really pretty much an experimental type of planning. Right. We're going to be focusing today, though, on exploratory hypothesis development, because what I'm hoping and what I think we may see in our group today is that you have a data set and you're not exactly sure on how to handle that data set. And so what I'd like to try to do is do a little bit of discussion on exploratory hypothesis development. And we're going to use three things. And I'm going to tell you what I use. I'm not saying this is the only way to do it, but there are basically three things that really make it very helpful for doing exploratory hypothesis development. Number one is have a spreadsheet that you're really familiar with, like Excel, and know all the buttons on Excel. Number two is have a really handy data transfer software program. I like independent ones, but a lot of the statistical packages have their own data transfer. The third thing is have a really good statistical package. And I think as busy clinicians, you may not want to get into doing SAS. I mean, I was trained on SAS. And you have to learn subroutines and have these subroutines set up. It's better to go to things like Stata, which have pre-designed subroutines and make it much easier for you to do your work. So those are the three things we're going to be talking about. And we're going to be talking in terms of exploratory analysis is using what we call Tukey type methodology. John Tukey is a Princeton professor in the 70s, developed a way of analyzing data. And it's pretty much, it's pretty eyeball type of thing where you do, box plots and stem and leaf and QQ plots. And these types of methods help you to get a sense of what your data is showing. And these are things that I think are very helpful in doing a preliminary analysis and getting an idea on what you should do for a hypothesis. Now, what you need to do initially are just some very basic things. You need to identify your independent variable and your dependent variable. And even at this point in my life, I oftentimes get mixed up. What the heck is our independent variable? What's our dependent variable? One of the ways of determining that is that, if you have exclusion inclusion criteria and you're defining something, that's going to be an independent variable. That's going to be something you define. On the other hand, if you're looking at outcome measures, you're dealing with dependent variables. And if you think about it in mathematics, function of x equals y or y equals function of x, it's basically your independent variables are going to be predicting your outcome measures. So it's important to define those.
Can you, David, at this point, give us an example from your studies of dependent and independent variables?
A classic one is just the patient, the subject is an independent variable. That's an individual. Now you may have, and we're going to talk about the issue of time as well. And I guess I'll bring that up now. Time variable is another one that can really define both, can define either your independent or dependent variable, but in the independent variable, time can be before and after. So these are independent variables. You could have the individual before and the individual after. These are independent variables.
Thank you.
That are going to predict some sort of outcome. So that you need to start to do this mental concept of what's your independent variable, because this is going to predict a lot of things that you need to figure out as you develop your model, your study. Other types of variables which are important are to try to distinguish whether you have a continuous variable, whether you have a categorical variable, or whether you have a memo. Now continuous variables basically are just continuous numerical measurements. Categorical can either be dichotomous, meaning yes, no, or it can be actually a series of categories. And memo is a little funky. It's like, you got to type in some information, and then you may, at this point in your research, you may have to interpret what that memo says. So this is part of using maybe analysis post hoc in terms of memo. And finally, the final variable is time. And time can affect both your independent and your dependent variable. Time affects your, as I mentioned earlier, independent variable like before and after type of thing. In terms of the dependent variable, it could predict survival, for example. Survival analysis is pretty much a dependent variable that is defining time. So time variability, the type or quality of the variable, like categorical, continuous, memo, and finally whether it's an independent or dependent variable. So these are all qualities of your data set that are important to define in your head, because this is going to help you think about how you're going to make your hypothesis. So it defines, for example, your statistics. For example, comparing categorical independent to categorical dependent is commonly used by like chi-square, odds ratios, and logistic regression. Comparing an independent categorical to continuous is oftentimes a t-test, or it could be ANOVA, or it could be a linear regression. Comparing continuous independent to continuous dependent is commonly correlation or linear regression. And comparing continuous to categorical is oftentimes what's called logistic regression. So your statistics really are defined by what you're dealing with in terms of the quality of your data or the type of data. Finally, the change with respect to time may define whether you do a repeated measures, which would be something you would do if you have a repeat of the independent variable, versus looking at survival statistics if you're doing a time measurement of your outcome measure. So these are all things that are important to look at.
And David, all these measures should be in your head before you start putting the data together, or even before you plan. When do you have to give time to that?
I think that if you're doing exploratory, you can certainly you're going to be dealing with all this stuff before you start. If you're doing observational, a lot of this stuff is done post hoc. And in fact, you may actually even change what you look at. For example, there are interchangeabilities between categorical data and continuous data. For example, if you have a continuous measure, you might want to talk about the lower 50 percentile and the upper 50 percentile as a categorical measure. And sometimes that actually gives you an advantage in doing your analysis. So there's interchangeability between data types, and a lot of stuff can be done post hoc. It can be done now when you have your data. How are you going to handle that? And so that's important to keep in mind as you're putting this together. The other thing about the Tukey methodology is that you can use this to see whether statistically you're going to be able to validly use certain types of statistics. You have a normal distribution. Is your variance too wide? Do you have a lot of outcome outliers? Because these all affect your data, and it can affect the way you choose your statistics. So doing your Tukey analysis during this post hoc evaluation can be very helpful as well.
That's a good advice.
I'm not sure what time how much more time I have, but what I might do later on is talk about a little bit of the fine tuning of this stuff, and then we can, if there are questions, that type of thing.
Sure. So now I would like to turn to Dr. Kirgiou. Welcome again. I want to ask the question that some of our audience, the participants, ask. How can I increase the chances of acceptance of my paper or abstract? And I'll tell you why I turn to you. You are very well published, and you publish all kinds of studies, including meta-analysis and including original research and some translational research, everything. So tell us your secret, in other words.
It is the case, and I think if you look at literature and how the structure of research papers are, it's very important to understand that no matter what paper you write, the principles of academic writing are the same. It is the case that I've done lab work and papers to meta-analysis and clinical trials, and no matter what you're trying to publish, I think you should think and try and spend time to learn how to write academically. That takes time, and this is something that many people don't realize. It doesn't come as a gift. Of course, some people can do it easily than others, particularly if English is not your first language, as it isn't for many of us. It takes a lot of training, and a lot of that, I think, comes from first reading very high quality papers and how those papers are structured. At least when I was a junior doctor, this is the way I did it. I used to read papers from very, very well written papers and try to mimic the way they would structure this paper when I was trying to write mine. And at the beginning, when I started doing meta-analysis, one of the biggest benefits of this work was that I had to read hundreds of papers and extract data from hundreds of papers. And apart from doing the paper itself, this gave me a lot of experience into how people structure the papers and how people write the papers. And when you try to extract data from papers as a junior researcher to do meta-analysis, you just realize that in some papers, everything is so clearly written and you can immediately get to what you want. And some others, you're like, they're looking for 2 hours to find the number of patients that had a surgical procedure, and it's impossible to understand what is going on in the paper. And slowly you learn how you need to structure these papers. I believe that after many years of writing papers, that the way you actually present a paper, you may have done excellent work in the lab or a clinical study or a meta-analysis, And then the time comes for you to write it down in a paper. And this is where even excellent work can become badly presented and the paper is not going to be accepted. And sometimes more average work, if presented in a very nice way with clear messages, may have a better outcome. I think the way I approach research papers is that I start from what is the main question that this paper is trying to answer, and that should always be the last sentence in your introduction. What is the aim in simple words? Not try to squeeze in the outcomes in the middle of a sentence, but what is this paper trying to do? It is trying to identify, I don't know, women that have had treatment for CIN and assess the impact that this may have had on their subsequent pregnancy. I don't know, whatever you want to use as an example. In that sentence, you can write that sentence and include all the information that somebody needs, i.e., what is your population, women of reproductive age, what are they having, and what are you trying to assess, and write this in a very clever way. And then you can read the same sentence and really not understand what your population is, whether they had a history of treatment, whether they're having a current treatment, whether they're currently pregnant. And when you read lots of papers, you realize that people struggle to pass clear messages when they do academic writing. And I think that's the most crucial one. I then always start with my methods. And you have to think carefully, what is your design? If you were to put in bullet points, what is your study design? Is it retrospective, prospective? Is it a meta-analysis? Is it a randomized trial? What are your inclusion criteria? What are your exclusion criteria? What are the type of population that you're dealing with? What are your outcome measures? What is your primary outcome measure? What is your statistical analysis? And what is that analysis going to answer? Is there a sample size calculation? Is there a statistical package that you're going to use? So when you read the methods of the paper, all of these aspects should be easy to find, not try in the middle of extracting data. When I was reading papers, trying to understand which actually was the population, because the results section contradicted the methods. So the messages should be very nice and clear. And as the time goes by, then you learn how to prioritize information in the main text, and everything that you don't think is that important can always move to your supplementary material. In terms of then writing the result, the structure always has to be the same. You start with an opening paragraph that is describing your population if it's a study, or your studies if it is a meta-analysis, and that has to have characteristics of patients, let's say in a comparative cohort study, and that has usually a table that talks about who has been included and whether there are any statistical differences. And quite often people, when they start then putting this into this table of characteristics in the text, they make it quite dull, in the sense that they start repeating the table in the text, and that's not useful. All the reader wants to do is get an idea of what is the summary from this table. What are the bits that you can bring out in 2 or 3 sentences on the actual elements that are different between the populations that you're comparing? They don't want to reread the table in a text. It is very hard to follow that paper, and then you miss the good information in the middle of all the unnecessary. So how do you push the details to the tables and your figures, and you keep the essence into your text? Then when you present results, I think it's also important to structure it in subheadings. So if you're looking at recurrence, then you have a group of outcomes relating to that. If you're looking then at another group of outcomes like reproductive outcomes, you have a separate group. People like structure, otherwise they get confused when they try to find information that has no structure. And when my fellows write papers and I correct them, I always say that you need to start with an opening line that gives to the reader the understanding of what you're about to present. Most of them start the paragraph by giving numbers and rates and p-values and confidence intervals, and the paragraph finished and you've lost it completely. What was the outcome of this paragraph? Is there a difference or is there not? Whilst if you start with a beautiful opening line saying, when women that had this were compared to women who had that, there was no difference in the effect of the surgical treatment on their, I don't know, pain threshold. And then you can expand on this underneath and put information on what is the actual important elements from your statistics, bring your statistically significant results, and then you quote your table where people can go and find more, less important information about things that were not statistically significant. And you need to know how to write this. How do you pull out the information that is significant in the text? And then just, you may write 3 words, none of the other outcomes were significant, and then the reader can go to the table and read about them. Then I usually write the introduction after this, and the introduction should be very targeted and short. I always tell my fellows, your introduction, 400 words, 500 maximum. You don't want to repeat your introduction in your discussion. You want your introduction to be relevant. And most people, when they start writing papers, they start, cervical cancer or vulva cancer is the second commonest malignancy worldwide, and the paper is about, I don't know, HPV vaccination in women that have had conization. I mean, how is that relevant? Yes, it is, but a bit, but I think the introduction has to be compact, punchy, passing the messages that you want to. And the messages it has to be relevant to what the paper is about. If you're writing a paper about HPV vaccination, you should start on how screening and vaccination can eliminate cancer and how highly successful they were. Yeah, you need 2 or 3 opening lines that are relevant to the topic. And then you have to know your literature and write a paragraph where you summarize in an academic writing what has happened on the specific topic. Has there been studies that have been conducted, and what have they shown? And sometimes people write this in the sense that studies have shown that there may be a benefit, but this is not clear. I don't like that. I want to read that paragraph and understand clearly what has been done. Why are you doing this new paper on the same topic? What is the deficiency? It's very different to say there was a study that showed no difference, but the results are uncertain. And it's very different to say, in 2020, authors from a study from Sweden recruited 12,000 patients and assessed the efficacy of vaccination after treatment on the CN2 recurrence and showed no difference between the 2 groups. It's that is academic writing. Within a sentence, you've talked about the study design, the number of patients recruited, the outcome and the result, without having to present the 95% confidence interval for all the outcomes. But you've given the reader everything they need to know about this study, and what was the next sentence would be, however, this study did not differentiate between this and that and the other. What was the negative thing about this study? Why is this study not giving us the answer, which leads us to doing yet another study? And that is compact scientific academic writing. And then the last paragraph of the introduction should always be a bit of rationale. As this question remains to be answered, we performed this study because of this and this and this. And as I told you before, that should be the first thing you write, your aim, which should be the last sentence of your introduction. The other thing that I find people find very hard to write is the discussion. And the discussion can only be written again if you follow a specific structure, which I follow since I was a year 1 SHO. And this structure in my head always starts with a paragraph that gives the most important findings of this study. i.e. in this study of 1,200 patients aged between this and this, comparing this, we found that this was significantly increased. There was no difference, and you can write the summary of your opening line if you had only 3 minutes to present this paper in that paragraph. Then I always continued to talk about the putting this evidence in context with the literature. You can't really do this in the introduction, and you shouldn't repeat your introduction in your discussion. At the moment of the discussion, you have the ability, the introduction should give the reader the idea of, this is what we have, but it's not good for that reason, hence we're doing this. And then in the discussion, you have the time to say, we found a statistically significant difference in this outcome, which is in agreement with this study from the US, or which contradicts the study. And then you need to comment on why you think that is. It's not just throwing it in. Why do you think there's a difference in the outcome? That's your next sentence. However, that study only recruited women from, I don't know, if you're doing a study on surgery and cancer, only recruited women that were operated in non-cancer centers. Or you're doing something on, there was a difference in the age group that they've recruited. Something that would explain the difference in the outcomes needs to be in your discussion. Then the reader, by finishing this paper, should have had an understanding of why this is not answered. And now that you have a new evidence, how this compares to the rest of the literature, and why do you think this is correct or not? The next paragraph in my head, always when I write the discussion, is first main findings, second put it into context, and that may take several paragraphs depending on the number of outcomes you have. And then the last thing in my mind is always strengths and limitations. What is the strength of this paper? And what is the limitation of this paper? But within the description of your limitations, you should almost answer the criticism of the reviewers. You should have thought why this limitation has not been addressed. Is it not possible? Are there no data? And how would you respond to the reviewer who will criticize the same thing? Why you didn't do this if you identified as a limitation? What do you think a future study should be like to address this? And then I always finish with a closing paragraph on future studies and what are the remaining questions and how these questions should be addressed in the future. And it's always the same, my papers, no matter what kind of study design.
And all are accepted. Thank you very much, Mara. I very much identify with many things you said. You talked about the messages and they should be clear and so on. David, would you allow me to present a little bit of my own idea? Okay, I prepared a very small presentation. I know usually we don't present anything here, but along with what you said, I would like to show that thing. Okay, sorry. I'll have to turn. Oh, okay. Now it's ready. Okay. So I hope you can see that. Okay, so how to publish my research, and this is the editor's point of view. As I said, I'm the editor-in-chief of the journal. David was before me, so we all know what we are talking about. That's probably the journal that you will all aim in your studies. Okay, so how can I improve the acceptance rate? Here are my ideas after your discussion. Of course, the paper quality counts. It should be good. I mean, there are no tricks. It should be good. A good article, in my opinion, communicates its message clearly. And you said it, Mara. The message should be clear. There should be a message, and that message should be delivered clearly. It should be concise, clearly written, and clearly structured. I love the wow effect. When you send it to the reviewer or to the editor, say, wow, there's a message. It's very interesting. You should make the editor and the reviewers want to read it. Think about them. Think about your readers. They should be interested in what you write. Make your article short. This is my opinion. You don't need to approve that. Short articles, in my opinion, are more likely to be accepted, read, and cited. Reduce your article before submission by 25%. That's my point. A paper should have a message. Again, the message and that message can be written in 2 or 3 sentences. If you want to speak to your friend and say, what is your paper about? You should deliver the message in 2 or 3 sentences. The authors should intrigue the readers and convince them of the work. Invest in quality diagrams, another idea, and figures, because the best ones get shown time and time again in lectures, while papers with no visual content tend to be forgotten. So invest in quality diagrams, figures, and nice tables. You have a paper to write, you have data to put together, don't delay, start now. The order is important. Mara spoke about her order. I usually create an outline with the list of figures and tables. I begin to write the methods. It's easiest parts to write. Now I write the results and the discussion and the conclusion and the abstract. And then I go to introduction. As Mara said, the introduction is very important. Why was the study done and the relevant background to understand the study? And then the references. Now you want to submit it, check the journal scope before submission, of course, and ensure that you're submitting to the suitable journal. Read the author's guideline, don't skip them. Make sure that your article is well edited. Well, I know you will choose the journal according to the impact factor. One word about impact factor. The impact factor, for example, the 2020, what we received in 2022 is actually citation in 2021 to items published in 2019 and 2020. What are citable items? Articles and reviews. Non-citable items are editorial material, letters, and meeting abstract. Well, what can I say? They don't help to the impact factor of the journal. One word about our impact factor. This is still last year. This year it's not much changed. And the impact factor of the Journal of Lower Genital Tract Disease was 3.84 last year. And it was like a big jump since the year before. Thank you, David. There is a new citation indicator that some of you may know, and I think that this is a good time to mention it because you will hear it again and again. This is the JCI, the Journal Citation Indicator. It will probably replace the Journal Impact Factor in one of the days. Remember that this indicator is a normalized citation impact. It compares your journal to other journals at the same entity, for example, 4 times a year and so on. So here as well, this is the JCI of our journal. What is the rejection and acceptance rates of the Journal of Lower Genital Tract Disease? Well, unfortunately for some of you participants, the rejection rate is above 60%. And I think this is how we keep the high level of the journal here. How much time you think we return a decision? So it's about 18 days, not too much time to wait. I know some of my friends ask me, would they reject my manuscript in the Journal of Lower Genital Tract Disease if I am not from the USA or from Boston or an editor's friend? No, we have a double anonymous peer review mechanism now. David has introduced that right before he left. So you submit separately the cover letter, the checklist, the title page, and then the anonymous manuscript without the title page. So this is our journal. These are my tips. Good luck to you. I look forward to receiving your submissions. So this was my piece. I hope it let you rest a little bit, David, before I ask you to continue with your story.
Thank you, Jacob. One comment to add to your very nice presentation of how to make an editor want your manuscript. I think everyone needs to remember that, in spite of the fact you made a comment about editors' friends, we as editors are not looking at you and saying we want your paper or don't want your paper because we like you or don't like you. And at least in terms of the past statistics, a lot of it has to do with how your manuscript is going to affect impact factor, because that's basically the editor's bottom line. We want our impact factor to be up because that makes more people want to send their papers to us. And unfortunately, there is a pecking order when it comes to articles. And if you have a case report, I can tell you that in 5 years, I looked at the number of citations for case reports, and it was close to one half of one. So basically, your impact factor was influenced by 0.5. Now, this is at a time when we want impact factors of 3 and 4. So if we accept your case report, we got to find a paper that's going to be like 5 or 6 citations to balance out that. So it really has probably less to do with whether we like you or don't like you as much as how you designed your paper. And I would say that if you have a control group and you're going to do a retrospective study or a prospective study, you're actually going to be better off in terms of getting published than if you are doing qualitative data like a case report or a case series. So this is sort of in addition to what Jacob has said. And you actually can add control groups. There is an open science movement at the present time, which permits people to get historical data as controls. And so don't necessarily think if you don't have a control group, you can't find one. There actually are available. There's a group called GoFair Initiative, GoFair, and there's the re3data.org, which actually gives you a whole series of data sets that have a historical control. So keep that in mind if you're publishing. Control groups are actually going to improve your chances of getting published.
But just to clarify, David, also thanks to you before you left, we reintroduced the case reports, and we tried to publish only, extraordinary case reports.
And certainly extraordinary case reports are going to be cited, but
right.
those are far and far between, frankly. So I think if possible, if you're going to try to publish a paper, try to do it with control groups and with design that involve that. And I don't want to steal all the time, but basically there are other things you can do in terms of the nuts and bolts of looking at a research paper. One is actually to go back and revisit sample size even after your data is completed. Because one of the questions, especially with retrospective stuff, is did you have enough of an N to actually be able to show an effect? And so looking at sample size, reanalyzing that, maybe that's not the best statistic that you should use. And then figuring out whether stratification, whether subdividing your people, your independent variables will actually help you in finding a statistically significant result. So stratification of your data can be helpful. A group that's older versus a group that's younger, is there a different outcome? Is there a difference in outcome with racial differences? These are all things that are independent variables that you can stratify after the fact, and you may find something very interesting by doing this. This is all stuff that you can find by just looking at something on a spreadsheet and breaking it down by stratification. And you can start to see trends in your data between the independent variable and the dependent variable, which might turn out to be very interesting. So that's why using the spreadsheet initially, just get a gut feeling of what's going on with your data, can be very helpful in producing a paper. With that, I'll pass it on.
Well, very good, advices, and give me some more advices to the young people that are listening to us. Or maybe I'll turn now to Mara. Mara, you know, you were involved in two types of studies that I'm interested about. First of all, as part of the ESGO and other organizations, you published some guidelines and reviews on various aspects of our profession. Tell us about your experience with preparing, you know, such big data sets and publishing them.
I think that there are, I guess, two separate big groups. I think in the way you write papers, there are the research papers, and that can be studies, lab work, clinical trials, or meta-analysis. All of this is research work and has a specific structure to it. Whether you're recruiting patients or you're recruiting papers, recruiting in a way that you're doing a systematic review, it's a research work, and it has to be done that way. And then there's another group of papers that are slightly different in the way you approach them, and they tend to be reviews, opinion papers, statement papers, and short guidelines, or at least, if not a guidelines, impact papers that can give a summary in areas in medicine that may not be as clear to produce an actual guideline, because there may not be the evidence there, where the opinion of the experts becomes really the guidance to clinicians. And those have a very different structure, because you're not using the same principles for a systematic review and meta-analysis. It is really, of course, something that needs a review of the literature and very good knowledge and summary in your introduction and rationale of doing this. But the most important thing is that you need to come up with recommendations that are not necessarily always evidence-based, because if there were, there would be a guideline. And there are areas that clinicians still want to hear from the experts what they think is the future and what they think they should be doing until such evidence becomes available, if ever, to produce a guideline. And I think you've all heard about level A, level B evidence, and how you support statements in guidelines where you give the level of evidence that support this statement. And I think the most difficult thing about these papers is to identify who should be involved. You need to ensure that you have good representation for all aspects. So you can't write a paper on a specific topic that may include, I don't know, a lesion of the cervix or the vulva, or something where the diagnosis is important, and not include a pathologist as part of your group. You can't not have clinicians, but yet again making clinical recommendations. And there are ways to approach this. You first need to identify what your group is, the focus group, which members are experts in the area. One person is never enough. Obviously, in each topic, you should have more than one representation of opinions. And then try to bring a draft of ideas of what should be included in that. Get each society of experts, clinicians, pathologists, statisticians, to bring together their strengths in what kind of things they can assess. It goes different ways. Eventually you can have like a voting system where there can be a voting from this predefined group as to whether they all agree with that statement, or whether there is a disagreement. And if there is a disagreement, this has to be debated, because it has to be resolved, or sort of worded in a way that this will be seen to the reader that this is an area that continues to be in a debate. And that takes an art on how to write something. But first you need to establish your group, and then you need to ask everybody as to what they think about this certain recommendations, amend the paper, and make sure that in areas where the evidence is limited or not everybody agrees, you can say something, there's still no agreement as to, you know, what's the role of neoadjuvant chemotherapy in the treatment of cervical cancer, and then you need to put that in, or in a CN2 untreated, there's still no agreement about P16 immunostaining to, you know, something that will show that they're opposing opinions, yet none of them has good evidence to support one way or another. And I think those are very useful pieces of work to do, because there are people that have dedicated their lives into a specific area, and if they write something about, I don't know.
Right. You know, maybe...
Your talks I hear sometimes about vaginismus. I think nobody in the world will do trials on this versus the other, I think, in many areas, but hearing it from somebody who knows more about it than most people, and bringing a group that can support different areas is very, very important, because that may be the best evidence that, you know, the best thing that anybody can use as a clinician to guide themselves.
This is very interesting. You know, would you recommend to a young investigator to search for deficiencies in our literature or in our practice, and find ways and what to do, and what to compose, what kind of guidelines or what kind of meta-analysis to compose? What do you think?
I think that, given that I think that this statement opinion papers are very separate to meta-analysis, because the one is a research paper and the other one is not, I think usually I'm of the opinion that the expert opinion papers should be led by very senior figures in a specific topic. And yes, of course, junior researchers can contribute with a literature search, but it is something that should be written by the expert, I think, and an expert committee of very senior people. In meta-analysis, my opinion is very, very different. I think inevitably senior people may have a better understanding of what is still not answered in their clinical practice, so they can guide junior clinicians on what the interesting topic is. What I find very, I mean, I'm still doing this, by the way. I was reading one of the guidelines from ESSGO the other day on fertility sparing treatment for endometrial cancer, and within the hour I had like at least 3 ideas by reading this guideline about meta-analysis that can be done, because
Nice.
I could immediately recognize that nobody has looked into, I don't know, comparison of the Marina versus this, and immediately within a second I got 3 meta-analysis ideas. So the best, in my opinion, way to figure out what is unclear is to read the guidelines on the topic, highly rated guidelines. So you can open the Colposcopy Society, the BSCP, and the Colposcopy guidelines in the UK, and you will know immediately the areas that are unclear. You can open the ESSGO guidelines and immediately find the areas that have not been answered, and get ideas of, yeah, they describe these papers, but there's no meta-analysis. How about doing one?
Very good. You know, one more thing that you mentioned is coming to an agreement on some controversial findings. And that reminds me, when I was chair of the terminology committee of a few committees, actually, we had a lot of arguments, I must say. My main task was to make peace. People were arguing. Remember that when I was chair of the colposcopy terminology, there wasn't too much evidence-based data. So everybody said what he thought should be. So we had a lot of arguments. I wonder how did you solve the arguments and the controversy while coming to an agreement and a conclusion? That wasn't easy, I'm sure.
I have to say, I've never personally been in a situation that there's so much intense disagreement on a statement. I know there have been in many other guidelines that I've not been part of, but I think when you come to that point and you listen to the one and the other side, you just realize that if both sides make an argument and they're supported by evidence, that the area is unclear. So when you write the sentence in your opinion paper, then you write it in the same way that although, I don't know, P16 immunostaining has been proposed as a marker to define high-grade disease, studies have contradicted its value because of this and this and that, and then you just leave it like that. You can't resolve necessarily something like that. And if you're writing about a surgical treatment for something that doesn't have a lot of evidence, and there are two surgeons with very opposing opinions, you just have two groups of surgeons with very opposing opinions. You just have to reflect that and say, the role of this operation remains debatable. That's all you can say.
Good idea. Well, we are approaching the end of our session. David, few words to end it.
One thing I think that's interesting in terms of our areas of research is that we have this divergence between those that are doing HPV science and those that are doing science in other parts of the lower genital tract. And HPV science, in my opinion, is one of the best understood areas in medicine. We understand what causes it, we understand how to prevent it. And we're comparing that with an area, say, such as vulvar pain or other types of vulvar dermatoses, where there's huge amounts of controversy. And so I think one of the reasons why we actually may see more arguments between those that are dealing with pain and other types of dermatoses is that we don't have the data there that the HPV people have. And it's always been a problem with our area of research.
You envy them. Yes. Any final words, Mara?
Not from me.
All right. So I think we are approaching the end of our hour. I enjoyed it very much. I hope you did the same. I'd like first to thank Professor David Foster and Professor Mara Kirgiou for taking the time and join me in that important session. Thank you very much for that. And for you participants, thank you for joining us as well. Please consider joining us also for either or both the World Congress of the ISSVD in Slovenia or the Biennial Conference on Diseases of the Vulva and Vagina in Chicago. And of course, join the ISSVD at issvd.org. Thank you, everyone, and have a wonderful evening. Bye-bye.